Friends, I think this is our third educational symposia of WFNS Education and Training Committee. And we are having both spine and craniocerebral sections. The first section will be 1 hour long on the spine, and then 1 hour long craniocerebral topic. Welcome to all of you, and I want to invite two moderators, Dr. Yahya Güvenç and Dr. Aderem Haydara, for moderate this session.
Thank you. Thank you, Professor. Hello, everyone. Welcome. On behalf of the WFNS Education and Training Committee and the WFNS Young Neurosurgeon Forum, we are glad to receive you on this webinar dedicated to the management of lumbar spinal stenosis. I am Professor Haydara, Head of Neurosurgery Department at University Hospital of Bouaké in Côte d'Ivoire, and I'm also Vice President of CANS for West Africa. I would like to express my gratitude to Professor Zileli for choosing me as moderator of this session alongside Professor Güvenç. Lumbar spinal stenosis management is an important topic, and we have three expert spine surgeons to talk about it. We are former members of the WFNS Spine Committee, and I would like to take this opportunity to salute Professor Sharif, the former chair of the committee. So I want now to introduce our prestigious speakers. The first one is Dr. Nikoley Peev from United Kingdom. He is consultant neurosurgeon and permanent spinal surgeon at Belfast Health and Social Care Trust, Northern Ireland. He will talk about surgery or conservative treatment of lumbar spinal stenosis. The second speaker is Dr. Mirza Poslik from Germany, who will talk about decompression, when and how to do it. And finally, Professor Zileli from Turkish will talk about fusion techniques, when and how to run or perform them. So we can go for the, if Professor Güvenç have to add something before we start the talk. Thank you.
Thank you, Professor Haydara. And we can immediately start with Dr. Nikoley Peev, the first topic, surgery or conservative treatment. Please.
Okay, so let me share my screen now. Okay, do you see my screen?
Yes, yes.
Okay, right. So thank you so much for inviting me for this webinar. It's a pleasure being here, and I will share my my experience with the topic, and it's my honor to be with you today. Thank you so much for the organizers. Special thanks to Professor Zileli and to all the moderators and everybody sharing their weekend time with us. So lumbar spinal stenosis. So I think I have to just open with a few words because the rest of the topics are covering the rest. So this is what you will read if you go to the website of the World Health Organization, that everybody that's living now at some point will meet a spinal surgeon. And the majority of this will be because of spinal stenosis. The spinal stenosis is the second reason for leave after flu. That's what the statistics say. So before I continue, I have to just introduce here the biopsychosocial model of the disease, and in particular, that's valid for people with spinal stenosis. People are getting older everywhere around the world, but in particular the Western countries where I practice. People have unrealistic expectations and would like to be completely free of pain. They would like to still achieve at their 60s and 70s the way they were achieving in their 20s and 30s. There is also very big interest in the healthcare from patients, media, lawyers, not the last place. Patients also are chasing different secondary goals, which is the social part of the disease. So all this has to be considered when we treat our patients. Unfortunately, we still cannot heal the spine, and we treat the spine, and that's what I told my patients. And quite often I tell them, unfortunately, if I operate you, I will not send you back to your 20s. You will still be 60, 70. We can improve, but we cannot make it better. We cannot make it perfect. One of the most common conditions for why patients are seeing physicians, the commonest, as I said, after flu, for days of work or ill retirement, it's a heavy burden on the health systems and heavy burden on the economy because of the productivity losses. The condition is also associated with aging. The population-based studies show that in the 4th decade, 2-3% of the patients will have degree of spinal stenosis and problems, but in the 6th, 7th decade, it will be 10-12%. One of the most common conditions for surgery over 60s, and if we have to say something about the gender prevalence, slightly selecting women. If we have to classify it, a few words, it could be idiopathic, or it could be congenital, idiopathic or achondroplastic, or it could be acquired because of aging in terms of degenerative, iatrogenic, post-traumatic, or sometimes there is certain conditions like Paget's or fluorosis that can give stenosis as well. We can discriminate central, recessual, foraminal, or total stenosis. If we have to say about the pathophysiology of the disease, it starts with intervertebral disc changes, dehydration, nuclear pulp because degeneration, hypertrophy, laxity of the facets, osteophyte formation. The intervertebral foramen is developing up-down stenosis and osteophyte formation as well. And then as a result, quite often spinal instability and dynamic stenosis. So this is a good scheme that shows you what's happening. As you can see here, the disc is dehydrating with aging, and then that is giving loss of tension and then instability, and that gives non-physiological load. And as a result of this cumulative damage and changes, herniations, osteophyte formation, and that's the reason for the stenosis. Your patient usually will tell you that he has kyphosed over the years. And this is what you will find in the spine if you do sections. You see that the disc is collapsed. There is disc osteophyte formation here. The yellow ligament is hypertrophied and buckled, and then the intervertebral foramen is narrow, and that's all is giving you the symptoms. You have to consider that there is a static element of your patients, but also there is a dynamic element. Quite often, the patient will be stooping forward in order to overcome this problem. As you can see here, when the spine is flexed, there is not much of a problem, but when the patient is erect with the usual lordosis, then because of the buckling of the ligament, buckling of the yellow of the disc, there is a narrowing and the patient becomes symptomatic. This is the symptoms pathophysiology. There is a nerve compression. There is a vascular compromise. There is usually mediators of the inflammation, and some authors also report demyelination, which could be the case in the advanced stages. When you see these patients, you will hear about neurogenic claudication in the majority of them, especially in the advanced stage. Back pain will be quite consistent symptoms. Kyphosing and deformity could be quite often also seen. Neurological deficit is possible, but is not the first symptoms that the patient will share. It's relatively rare occurrence. From the examination, claudic and back pain, the patient walks stooped forward, and because of the dynamic element that I showed, the patient is stooping to overcome the radicular problems, but like that is deranging the sagittal balance and is paying with back pain. Neurogenic claudication is also very usual symptoms. Weakness is possible, but not typical. Lumbar extension quite often provokes the symptoms. How are you going to diagnose that? X-ray, standing, with my practice, usually standing X-ray, lateral X-ray, AP. Lateral is what I do minimal. Dynamic X-rays is sometimes what I would consider, especially if I'm concerned about instability. MRI is obviously standard. In most of the centers, you can have access to static MRI scan, but more and more centers are providing now dynamic and weight-bearing MRI scans. CT and CT myelogram, that's in my hands, that's a reserve investigation in case I cannot do MRI scan for different reasons. Or sometimes in case I would like to see calcification, then obviously CT scan can supplement, especially with previous surgeries. Nerve conduction test and EMG is something that will supplement your investigations. 10 millimeter mid-sagittal diameter is something that will orient you to think about stenosis or less than 100 square millimeters overall area of the cross-section. However, this is not absolute measurements, and I will show you a case later on to demonstrate that. So usually one of the most common problems that the patients will present with usually is self-limiting. It will resolve in 4 to 8 weeks in more of 50% of the cases as per the research. And then in 6 months, it will go for the majority of your patients. Unfortunately, there is a high recurrence rate. The patient will get better, but later on it might come back with similar problems. So if you don't have red flags, if you're not worried, probably the best approach for these patients is to wait a while, to try to entertain them with some physiotherapy, sometimes injections even, and then the majority of them will get better and you would not operate them. A radiculopathy could be an indication for surgery. If the patient is having radicular symptoms, I would normally try to demonstrate that with MRI scan, and we'll try to corroborate the picture on the MRI scan with what patient is saying based on the dermatomal selection. The patient having weakness is something that will alarm me, but if the weakness is not so severe, I might wait a while and see if that's going to resolve. But if the weakness is less than 4 out of 5, I will consider surgery. A long-standing weakness more than 2 months is something that will prompt me to do something, or long sensory is also something that will prompt me to do something. Usually long sensory or long motor deficit is not good prognosis for complete recovery. So also, apart from neurological deficit, I would consider operating patients which are over 6 weeks of severe pain, or if they have pain more than half of the year, and they're relatively young and high functioning. This is something also that would be a considerable reason for me. The goal of diagnosis, I will try to define the pain source, and I will try to define the level where the problem is coming. Not always possible, because most of these patients will come with multi-level disease, and quite often you're not sure exactly where the pain is coming, but in most of the cases we are possible to get oriented. I just want to remind you the red flags. You have to be cautious when you're treating these patients because most of these patients will be old and they will have chance to have other problems which will not be possible to be left to wait, like cancer history, weight loss, fever, chills, pain is not improving with rest, urinary retention, fecal incontinence, saddle anesthesia, progressive weakness. All these things have to make you think for something else happening, but not just simple stenosis. I was talking to you about the claudican back pain. That's why I wanted to present to you a video. Let me see if that video will start. Unfortunately, the video is not starting. Let me see if I can do that. Yeah, unfortunately, the video is not starting for some reason. Apologize for that. I'll try to play it a bit later, maybe. But the point is that this patient is walking stooped forward. You can see the radiograph of the erected position, and the reason is the patient is stooping forward because like that the patient is decompressing the neuroforamina by opening them, but like that the patient is deranging the sagittal balance, and yes, that is helping for the radicular leg symptoms, but that patient is paying because of that with back pain. Facet syndrome is something that many of your patients will have. They will tell you that they like to, or you will see that they are leaning, or they like to go shopping and they lean on the trolley when they are leaning. So this is something that most of your patients will have with degenerative changes. You can see facet sign here that is very prominent. Most of these patients will still benefit with physiotherapy and combination of physiotherapy and injections. So injections are an important part of my practice in the management of these patients, especially for back pain. I do diagnostic injections to diagnose the level where the problem is coming from, and I do also therapeutic injections. You have to stress to the patient that this is not a standalone procedure that provides a window of opportunity for the patient to start exercising, and like that, retaining the results for longer, going for physiotherapy, exercising, mobilizing themselves, and like that, trying to retain the result. Nerve root injections is something also that I would consider for radicular type of pain. I would do it in a standard way with like 4.5 centimeters offset, but quite often if the canal is very stenotic, that is very difficult to penetrate the canal width. So I will go a bit more laterally. This is nearly mimicking the trajectory of the transforaminal endoscopy if you're doing endoscopes. And for that, I'm using a bit longer needle, and I will have penetration in the foramen in 100% of the cases and good results. Just to point, sacroiliac joint problems. Many of your patients will have sacroiliac joint problem, and that will be obscuring your symptoms or mimicking different symptoms. So think about that. And last words, extremely high incidence of the spinal stenosis. If you exclude, you have to exclude the red flags or trauma. If you exclude that, you can wait, and 90% of your patients will go away without anything else. You have to reevaluate if the pain lasts for longer. You have to obtain the necessary imaging. Look for specific biomechanical causes and try to identify the pain generator. Injections are something that are helpful, so you consider that. Consider SI joint in the pathogenesis of the symptoms. And that is from me. The last is, I wanted to show you, this is a patient that I follow from 2016. And he doesn't want to be operated. He is a high court judge. Obviously, I'm a bit alert from that. At least where we practice here in UK, litigation is on a high, and we are always alerted when we see patients like that. The patient doesn't want an operation. The patient is just having back pain come and go. And I'm following him already for 8 years, and he's well, so I'm not operating him. Thank you so much.
Thank you, Nikoley, for the great talk. We can go forward, or we take some question, Salman?
You can take questions, no problem.
Okay. Any question or comment, please?
Manuel wants to say something.
Yes, maybe a protocol to know which one is the best performance, the best procedure for this kind of patient. Because sometimes you have a patient who have the foraminal stenosis, for example, and there is a different stage of the foraminal stenosis with neuropathy and without neuropathy, stable or unstable. So which one is going to be the best way to treat this kind of patient according, if you have a algorithm, for example?
Manuel, if you have to answer extensively that question, we can start now and we can finish maybe tomorrow same time. I think that
Okay.
What is the best procedure depends on many factors, depending on what is the clinical presentation of the patient, depends on how old is the patient, depends on how active is the patient, depends on what you want to do with that patient as well, depends on what is the best procedure in your hands as well. So many factors. So I can answer that question only in a general way, the way I'm doing it now. Otherwise, there will be so many ramifications. Probably some of that will be clarified by the other two speakers. One is speaking about when to operate and when not, and then this is Mirza, and then Mehmet is talking about when to fuse and when not to fuse. So basically, the procedure in general will range from the treatment will range from medical treatment and then physiotherapy. Then you can supplement that with injections. Then you can do simple decompressions, which vary from open, minimal invasive, endoscopic. And then at the end, you can do fusions. You can do one level. You can do fusion from top to bottom. You can do so many things. So you have to wait and see till the end.
Thank you.
There's a question from Nasser. Nasser, you want to say something?
Manuel.
Thank you very much for the wonderful presentation, Professor Nikoley. There are a few things that I wanted to ask you. You mentioned that radiologically on sagittal sections on the CT scan, you decide about the stenosis on mid-sagittal 10 millimeters of minimal length. Is that a cutoff standard for everybody? Because in most cases of spinal stenosis, it's the ligament and the periarticular ligaments that thicken, and use in size contributes more towards the spinal encroachment of the spinal canal.
So, sorry. Yeah, sorry, I thought you finished, but yeah, please carry on.
Yeah, that's basically it.
Yeah, so absolutely, this is not something that I follow religiously. This is just rough orientation. The case that I showed you, it's tighter than 10 millimeters, and I'm still not operating them. Sometimes there is patients which are less than 10 millimeters, and I would operate them. For me, the clinical presentation and the clinical signs and symptoms will be what's guiding me. Also, we have to always consider the dynamic element of it. So I showed you that picture. So there is absolutely no cutoff that I follow blindly, but there is many factors that I will reflect. And the main thing is how the patient feels and what the patient wants.
Thank you very much.
Thank you. Any question?